Welcome everyone, and thank you to those joining us live and to those listening afterwards. I'd also like to warmly welcome our guest today, whom I'll shortly introduce. Our webinar today is titled Cardiovascular Health, Medication Management and Adherence. Medication management is particularly important for people living with cardiovascular disease due to the increased likelihood of comorbidities. This often leads to the need for multiple pharmacological therapies, resulting in polypharmacy. Close medication management between pharmacists and CVD patients is essential to ensure effective achievement of treatment goals, ensure adherence, and reduce the incidence of unpleasant or fatal side effects, thereby reducing the burden of CVD. This digital event will address the importance of proper medication management and adherence in the successful management of CVD, the factors associated with non-adherence to CVD medications, and to economic impact of pharmacist interventions on CVD medication adherence. The next. Hello, my name is Virginia Olmos. I am pharmacist. I am FIP Vice President. I am from Uruguay. Next, please. For this event, we are joined by a panel of fabulous speakers, and I wanted to sincerely thank each of them for taking the time to prepare these presentations. Next, please. Thank you. As you can see on the slide, we have some announcements. Please note this event will be recorded live stream on FIP YouTube, and the recording will be available at events.fip.org. To all those listening, please feel free to send your questions through the Q&A box provided, and I will do my best to manage all the questions so that at the end we will be able to address those questions. You are welcome to provide feedback in webinars at fip.org. I would like to take this opportunity to promote the benefit of membership with FIP, including events and webinars. FIP is a global body representing over 4 million pharmacists and pharmaceutical scientists. If you are a pharmacist or pharmaceutical science and you would like to become a member, please register on FIP's website at fip.org. FIP wishes to thank Beatrice for supporting this event through unrestricted grants. Today's our program is the following: welcome and introduction by myself, factor associated with non-adherence to cardiovascular medications is in charge of Professor Pedro Amariles, professor and researcher on pharmaceutical care and clinical pharmacy, Universidad de Antioquia, Colombia, empowering pharmacists, enhancing medication management and adherence in people living with CVD, Professor Stefano Omboni, Italian, Institute of Telemedicine, Italy. The economic impact of pharmacist interventions on medication adherence in cardiovascular disease, Dr. Sean Ikena Owiwu, Center of Disease Control and Prevention, Oak Ridge Institute for Science and Education, Atlanta, Georgia, USA, discussion and Q&A, and wrap-up and conclusions. Today, we have some learning objectives. The first is the importance of effective medication management practice for cardiovascular disease, CVDs, and their impact on our on patient outcomes. The second is the critical role of pharmacists in optimizing medication regimes, educating patients, and implementing adherence interventions in the context of CVD management. So, the third is the factor associated with non-adherence to cardiovascular medications. And the last is the economic impact of pharmacist intervention on medication adherence in cardiovascular disease. Last year, SPIP launched 2 research for pharmacists on cardiovascular disease as part of FIP practice transformation programs on non-communicable disease, PTP and NCDs. Cardiovascular disease, a handbook for pharmacists, FIP, knowledge and skill reference guide for professionals' development in cardiovascular disease. The aim of the FIP handbook for pharmacists on cardiovascular disease is to identify and describe key evidence-based intervention by pharmacists in this area, with the dual aim of supporting their implementation in pharmacy practice and supporting advocacy effort by FIP member organizations toward the optimizations and or expansion of pharmacists' scope of practice in cardiovascular disease and NCDs in general. The FIP K&S Guide for Professionals Development in Cardiovascular Disease was built on the FIP Cardiovascular Disease, a handbook for pharmacists. It is a companion publication developed to support the professional development of pharmacists in the area of CVD by identifying the knowledge areas and skills required to provide the service and fulfill the role described in the handbooks. Next. These 2 publications and all publications related to the PTP and NCDs, such as handbook, K&S Guide, recording of the digital events and other resources can be found on the NCD's microsite in the website ncd.fip.org. Please check this website for updates. Okay, now we have a poll for self-knowledge. The first question I read for you, and I invite you to participate in this poll. 1. For solving intentional non-adherence, the intervention that could be more effective is motivational interviewing, educational interventions, shared decision-making, including the use of decision aids, or D, employing electronic databases. Please put there your answer. Well, we have the second question. Which item in the list may not be considered a direct pharmacist intervention on a multidisciplinary team? Monitoring patients, monitoring patients' outcomes, medication dispensing, collaborative medication management, detection, prevention, or control of specific cardiovascular risk factors. Well, the last question is number 3, true or false? The Community Preventive Service Task Force find tailored pharmacy-based adherence intervention cost-effective for cardiovascular disease preventions. Choose one, please. Well, we will do again in the end of the website the same questions. Now, I introduce the first speakers and I invite you to do the questions in the Q&A box, please. Our first speaker is Professor Pedro Amariles, is head of the research group on pharmaceutical promotion and preventions, Universidad de Antioquia, Miniciencias, Senior Researcher, Colombia. Associate Pharmaceutical Care Research Group, University of Granada, Spain, researching and academic producing on pharmaceutical care, clinical pharmacy, and regional drug use. Tutor of 12 masters and 8 PhD degrees, 4 in Spain. Author and co-author are near to 180 papers and 30 textbooks and manuals or guides for pharmacists. He is one of the authors of the FIP publications, Cardiovascular Disease, a Handbook for Pharmacists. Welcome, Professor Amariles.
Good morning and good afternoon to pharmacists from different countries in the world. Thank you very much, Dr. Olmos, for the introduction. Thank you to IP for inviting me to present some topics regarding adherence to cardiovascular medication. Next, please. In these 15 minutes, I focus to present some keys regarding 4 topics. Number 1, general concepts regarding adherence. Number 2, prevalence and effects of medication adherence in patients living with cardiovascular disease. Number 3, challenges and barriers to medication adherence in patients living with cardiovascular disease.
Professor, we can hear very well. It's very far, your voice. You can check your microphone, please.
Thank you.
Please try again, Professor.
Now, isn't it?
Maybe it's better. Please try.
Okay.
Yes.
In these 15 minutes, I focus to present some keys regarding 4 topics. Number 1, general concept regarding adherence. Number two, prevalence and effects of medication adherence in patients living with cardiovascular disease. Number three, challenge and barriers to medication adherence in patients living with cardiovascular disease. And number four, perspective to improve adherence to cardiovascular medication, mainly pharmacist intervention activities to improve adherence. Next, please. Regarding to general concepts, it is important to remember the concept of adherence. So, adherence is the extent to which a person's behavior corresponds with agreed recommendation from a healthcare provider. Next, please. Medication adherence corresponding to the process by which patients take their medication as prescribed. In this process, it is possible to identify three phases. Number one, initiation, also known as adoption of primary adherence. Number two, implementation, also known as persistence or secondary adherence. And number three, continuation. Next, please. The following graph shows these three phases in the associated three types of non-adherence. In this way, so if primary non-adherence patient does not initiate treatment. In a secondary or implementation non-adherence, patient denies, omits, or takes additional doses. And in continuing non-adherence, patient discontinues treatment. Please, next. Also, adherence could be
Mr. Pedro, can you please speak a little bit louder? We are having trouble hearing you, sir. Or maybe you can disable your headset. Maybe that's causing the problem.
How is it now?
Still the same. It was good at the rehearsal, but now it comes from far away. I think now it's gone completely. Maybe the earphones is disabling the sound. Maybe you can disable the earphones and we can hear you from the computer's microphone better. So it is quite possible that the AirPods is not receiving the sound really well. So maybe if you disable that and use the computer's microphone, I think that would probably solve the problem. Unfortunately, we cannot hear you. Mr. Pedro, what we can do is we can move to the next presentation, and if you can just log out and log in again, and we can fix the sound that way. And meanwhile, we can get the next presentation, and you can do your presentation afterwards, if that's okay, sir.
Well, I introduce the second speaker, Stefano Omboni, Director at Italian Institute of Telemedicine, Italy. He is a cardiologist and professor of cardiology at the first Moscow State Medical University. He published original papers focusing on blood pressure monitoring, telemedicine, hypertension, cardiovascular disease, and pharmacology. He's a member of the Italian European and Italian Society of Hypertension, the Italian and European Society of Cardiology, and the International Society for Telemedicine and e-health. We invite you to put the question in Q&A box, please, and welcome Professor Omboni.
Thank you very much. Can you hear me?
Yes, perfectly.
Thank you for the invitation. Cardiovascular disease is the leading cause of death globally. And why this? This for two reasons. First, access to primary care and treatments to improve cardiovascular disease and cardiovascular risk factors is really very challenging. But, and this is the focus of this webinar and also of my presentation, is because medication adherence in cardiovascular disease is reported to be suboptimal in many patients. In these slides, we can see that non-adherence to medications have been documented to occur in up to 60% of cardiovascular patients. Of course, the level of non-adherence may differ according to the type of drug that we are considering. Causes of medication non-adherence can be categorized into three major groups. I will not go into details because I think another speaker will deal with that. We have communication barriers, socio-economic barriers, and motivation barriers. Which is the role of pharmacists in cardiovascular disease prevention and management? There are at least three major roles. The first is the educational activities directed at patients. The second is informative activities directed at healthcare professionals. But what is most important is the direct intervention of the pharmacist within the context of a multidisciplinary team. And what is most important is the collaborative medication management and also the detection, prevention, or control of specific cardiovascular risk factors, such as blood pressure measurement, blood glucose, or lipids measurements. Usually, the pharmacist acts at two different levels: cardiovascular disease prevention and cardiovascular disease management. As far as cardiovascular disease prevention is considered, the task of the pharmacist is to take care of hypertension, type 2 diabetes, people smoking, obese, providing general lifestyle education, and metabolic syndrome. For cardiovascular disease management, the pharmacist may manage patients with chronic kidney disease, heart failure, coronary heart disease, stroke, arrhythmia, and patient taking anticoagulation drugs. The level of benefit of pharmacist intervention on different outcomes, clinical, humanistic, and economic in cardiovascular disease is not proved for all types of specific outcomes. For instance, the level of benefit is positive, and it is proved for blood pressure control, glycemic control, smoking cessation, medication adherence, health literacy, and quality of the medication use process. On the contrary, the evidence is not definitive for lipid management, metabolic syndrome, impact on morbidity and mortality. Evidence is strong only for heart failure. And of course, a question mark regards the impact on healthcare costs. The most common methods for measuring adherence are indirect measures, pill count, prescription refill rate, electronic monitoring of pill use, and also subjective measures that are based on self-reported questionnaires by patients. Of course, in pharmacy, direct measures are not usually applied. The intervention of the pharmacist to the patient with cardiovascular disease in order to improve adherence to medication is at different levels and is usually combined and multifaceted. It includes patient education and information, simplification of drug regimen, intensified patient care, complex behavior approaches, decision support systems. But what is most relevant, and it will be discussed in the next slides, is the pharmacist-led collaborative practice with other healthcare professionals, primarily the physician. There is evidence. This is a slide summarizing results from a meta-analysis of 7 randomized control trials. There is evidence that pharmacist intervention within the context of multidisciplinary team care may improve medication adherence in patients with heart failure. You can see here that most of the studies are favoring pharmacist care. But if we look at other conditions, the situation is not always so straightforward. For instance, Parajuli in 2019, in a previous meta-analysis in heart failure patient, show that there was an improvement in medication adherence with multidisciplinary team care. But the same was shown by another meta-analysis focusing on patients with renal failure. But if you look at other studies involving patients with cardiovascular disease, patients treated with lipid-lowering drugs of diabetes, first you see that the pharmacist, most of the studies did not include a multidisciplinary team care. And this still resulted in improvement in adherence. So the evidence from multidisciplinary team care effect on adherence is not definitive. Usually the effect of pharmacist intervention on different outcomes can be summarized such in this slide, with different interventions, including patients' education, medication management, measurement and management of cardiovascular risk factors, collaborative management with other healthcare professionals. These interventions impact on different humanistic and clinical outcomes. And the final effect is the improved adherence to therapy, the reduced mortality risk and reduced hospitalization risk that should have an economic impact in terms of reduced healthcare costs. Of course, it is also to be considered that there are barriers to effectively implementing pharmacist-led intervention to improve medication adherence. This because of lack of pharmacist time. A possible solution is the collaboration with nurse practitioner and increased involvement of technicians in the dispensing role, the lack of appropriate counseling space, the lack of pharmacist education or knowledge on the specific condition or disease, the lack of reimbursement, patient inertia, and very important, poor awareness of patients of the pharmacist's extended role and hesitancy to trust pharmacists to deliver unfamiliar services. Finally, we should acknowledge that there is a lack or poor collaborative care with other healthcare professionals, and this can be solved by setting up a professional network through telemedicine, and this will be shown in next slides. Telemedicine literally means the provision of medicine at a distance. Usually, telemedicine is summarized according to a closed-loop model, which is centered on the Internet of Medical Things, where different solutions, including drug management, telemonitoring, and tracking of different parameters, are used with specific devices or tools to collect data and communicate this information through the internet to different case managers, including the pharmacist, and in different settings, including the community pharmacy. The potential advantages of telemedicine services delivered through community pharmacies are several: provision of healthcare services otherwise not available, enhanced access to care, affordability, short waiting list, results that are quickly available, time and cost saving for the patient, but also for the physician, use of professional medical devices and tools, as in the hospital setting, services provided in a professional setting by healthcare professionals, such as a pharmacist, and interventions that may be provided in the context of a multidisciplinary team of care. The level of benefit of telepharmacy intervention on clinical and economic outcomes in cardiovascular disease is far from being proven. For instance, it is it's sufficiently proved for blood pressure control in arterial hypertension, but as you can see, there is a lack of definitive evidence for medication adherence to cardiovascular therapy. Here is a summary of different randomized control studies based on physician-pharmacist collaborative practice through telemedicine. You can see that this collaborative practice is associated with a significant reduction in blood pressure, both systolic and diastolic. But what is interesting, when the collaborative practice is withdrawn and the intervention is withdrawn to the patient, the positive impact on blood pressure is lost. Pharmacist-led telemedicine interventions to improve medication adherence are usually based on telephone encounters, automated voice messages with medication reminders and education, including IVR, text or electronic messaging and emails, video consultation and virtual management within a multidisciplinary team, and also remote monitoring of health status and tracking of drug use. As far as the impact on medication adherence of this pharmacist-led telemedicine intervention, first, we must say that there are few studies, that all these studies are not based, unfortunately, on multidisciplinary collaborative team care. And as a matter of fact, as you can see, in most studies, no positive impact on medication adherence was observed, except, for instance, for some studies, including hypertensive and diabetic patients. A possible solution is the use of mobile health. There is evidence, this is a meta-analysis of different studies, there is evidence that using smartphone apps and including a multidisciplinary team of care, we may obtain an improvement, a significant improvement in medication adherence. We have also to face important barriers to the implementation of telepharmacy services in the community, like the limited evidence of clinical efficacy, as we have seen before, the lack of adequate infrastructure and equipment, the high implementation and maintenance costs, the poor informatics literacy and healthcare workforces and patients. There are also privacy and security issues, lack of integration with traditional national healthcare systems, and lack of reimbursement models for services. So in conclusions, based on the current evidence, we can say that combined interactions or multifaceted interventions are more effective in improving medication management and adherence in cardiovascular disease through the pharmacist. Tailored approaches according to the type of cardiovascular disease or cardiovascular risk factor and subject attitude are preferable. Collaboration between pharmacists and other healthcare professionals, primarily the physician, enhances the chance of success. And finally, the use of telemedicine, so-called telepharmacy, may help increase the potential for success in improving clinical outcomes and enhancing medication adherence. Thank you for your attention.
Thank you, Professor Stefano Omboni. Very interesting your presentation. And now we continue our webinar with Professor Dr. John Ikena Owiwo.
Thank you for the introduction.
After this, Dr. Ikena, we continue with Pedro, but now Professor Ikena Owiwo is a translation research of Oak Ridge Institute for Science and Education's fellow in the Applied Research and Evaluation branch of the Division for Heart Disease and Stroke Prevention at the Center for Disease Control and Prevention, CDC. In this role, he works on pharmacy projects focusing on the translation and dissemination of evidence-informed pharmacy practice. He received his Doctor of Pharmacy from Northeast Ohio Medical University and Master of Arts in Global Interaction from Cleveland State University. Welcome, Dr. John Owiwo. We ask the audience that they put the question, please, in the Q&A box. Welcome.
Thank you, Virginia, for the introduction. As a disclaimer, today I'm going to be presenting on the economic impact of pharmacy intervention on medication adherence in cardiovascular disease. As a disclaimer, the information presented here today reflects the view of the presenter. It does not necessarily represent the official position of the Center for Disease Control and Prevention. For today's presentation, we'll start off with a brief introduction on the Community Preventive Services Task Force, which I will be referring to as CPSTF throughout my presentation, followed by an overview of the systematic economic review methods utilized by the Community Guide program. We will then delve into the results and findings, and lastly, we will conclude with a summary of the evidence. Next slide, please. At the end of this presentation, participants will be able to comprehend CPSTF recommended tailored pharmacy-based interventions to improve medication adherence. Participants will be able to also understand the key economic outcomes of these interventions, and lastly, identify limitations and evidence gap within the recommended intervention. Now I'm going to provide some background information on the Community Preventive Service Task Force. The CPSTF is an independent non-federal panel of 15 public health and prevention experts. CPSTF provides recommendations and findings on programs, services, and other interventions to protect and improve population health. Recommendations are based on systematic reviews of evidence of effectiveness and economic impact. The focus of this presentation will be on the Community Preventive Services Task Force recommended statement on tailored pharmacy-based interventions for cardiovascular disease prevention. These findings were based on strong evidence from the Community Guide Systematic Review, which found the interventions to be effective in patient adherence to medication for cardiovascular disease preventions. Additionally, the economic review showed that the interventions were not only effective, but they were also cost-effective. Next slide, please. Tailored pharmacy-based intervention aims to help patients with cardiovascular disease. Tailored pharmacy-based interventions aims to help patients with cardiovascular disease risk conditions take their medications as prescribed. Community or health system pharmacists use assessment tools or interviews to identify adherence barriers for each patient. Pharmacists then provide tailored guidance and services to reduce these adherence barriers. Some tailored guidance may include either focused medication counseling or motivational interview sessions. And the services may include one or more of the following: patient tools such as pill boxes, medication cards, medication cards and calendars, medication refill synchronization, and enhanced follow-up. Interventions may include additional components such as communication between the pharmacist and the patient's primary care provider or patient education material. Of note, the intervention may be done alone or may be a part of a broader intervention to reduce patients' cardiovascular disease risk. Next slide, please. The CPSTF recommended tailored pharmacy-based adherence intervention based on strong evidence of effectiveness in increasing patients' adherence to medication for cardiovascular disease prevention. Additionally, the CPSTF finds the intervention was cost-effective based on a median cost per quality adjusted life year gain of $11,298, which is well below a conservative threshold of $50,000. Next slide, please. We will now begin the economic review. Listed on these slides are the economic research questions. These are the standard research questions that seek to determine the implementation cost of the intervention and the economic benefits resulting from it, including reduced healthcare costs, improved worksite productivity, and the increase in quality adjusted life years lived. The key questions that determine the economic merits of the interventions are as follows. Does the sum of the economic benefits exceed the cost to implement? And are the cost per quality adjusted life years or cost per disability adjusted life years less than the threshold for cost effectiveness? Next slide, please. We will now go over the inclusion and exclusion criteria from the economic review. The inclusions included peer-reviewed evaluation studies, studies meeting intervention definition, which was previously discussed, studies written in English, studies conducted in high-income countries, and lastly, studies with information that answered one or more economic research questions. The exclusions included conference presentations and abstracts, studies in which the majority of patients have existing cardiovascular disease, studies where the majority of medications were not related to cardiovascular disease prevention, and lastly, intervention where the primary objective is medication cost reduction. Next slide. Listed are the search strategies and method used for identifying literature sources. The search period was from inception of database up until May 2019. Next slide, please. For standardization, all estimates were standardized to ensure comparability on a per patient per year terms. Summaries were are presented in terms of medians, and all monetary values are expressed in 2018 US dollars. Next slide, please. I will now present on the results of the economic review for cardiovascular disease prevention. Of note, the cardiovascular disease prevention review included 29 studies from the original search yield of over 7,000 citations. Here is a geographic distribution of where the interventions in the studies were implemented. There were no studies representing the Southwest region of the United States. In total, there were 22 United States studies and 7 foreign studies. The foreign studies were from Europe, China, and Canada. Next slide, please. The table to the left categorizes studies based on the type of the settings where the intervention took place, with most studies occurring in either primary care clinics or pharmacy-based setting. The table to the right provides information about the disease or condition that was the primary focus of the intervention and the sources of study funding. Notably, the most common disease focuses were hypertension, dyslipidemia, and diabetes. Interventions that had multiple disease foci also included the 3 conditions that were just mentioned. Pharmacists Association of Pharmaceutical Industry and Government or academic sources were the primary source of funding for these studies. They accounted for approximately 11 and 10 studies respectively. Next slide, please. Listed here is an overview of patient characteristics across the studies, summarized in terms of medians and interquartile interval. Overall, the sample sizes were of moderate scale, and the patient population primarily consisted of older adults with an approximately equal representation of males and females. The majority of the studies occurred in urban population, with some studies occurring in urban-rural mixes. There was a reasonable representation of minority racial groups in the study. The baseline measurement for blood pressure, LDL cholesterol, and hemoglobin A1C are provided. It's important to note that the blood pressure estimates include patients with diabetes and perhaps may be understated. Next slide, please. The pharmacist activities are listed in column 2, and the number of studies in which the activities occurred are listed in column 3. As expected, adherence-related activities were present in all studies as they were a required part of the inclusion criteria. The other common activities were patient education and patient lifestyle counseling. The activity of identifying or resolving drug-related problems was also prevalent because it involved standard pharmacist responsibilities, such as identifying inappropriate medication, inappropriate dosing, and adverse drug interaction. The less commonly observed were patient care services related to limited and basic diabetes physical exam. Next slide, please. This table displays the number of studies that provides estimates for the key economic variables specified in the research questions. Most of the studies reported intervention costs, and all the studies estimated the change in healthcare costs. There were a few studies that provided a single estimate for the composite of intervention costs plus healthcare costs, which is also the total cost. There were no cost-benefit studies. And of note, there were 6 studies, including 3 from the United States, that provided evidence for the cost per quality adjusted life year gained, as indicated in the last row. Next slide. I will now present on the summary of the results. Next slide. For the intervention cost in the context of cardiovascular disease prevention, the median cost to implement the intervention for cardiovascular disease prevention was $246 per patient per year. These findings were based on estimates from 19 studies. Furthermore, for the change in healthcare costs, The median change in healthcare costs per patient per year was negative $335. This negative value signifies that the interventions led to healthcare cost saving, which is a significant and positive outcome. Next slide, please. In summary, when examining the changes in the change in intervention costs plus change in healthcare costs, the median for intervention costs plus change in healthcare costs was negative 49, indicating a potential cost-saving effect. However, it is important to note that the interquartile interval crosses zero, suggesting some variability in the economic impact across different studies. Regarding the cost effectiveness of the interventions, the median cost per quality adjusted live years or live year gain was $11,298, indicating that on average, the intervention offered good value in terms of improving patients' quality of life and extending their life expectancy. The third quartile falls below the commonly cost effectiveness threshold of $50,000, which suggests that the interventions are cost effective. Next slide, please. In this session, we will go over the limitations and evidence gap of this economic review. Listed are the limitations of this review. Overall, it was often challenging to distinguish the specific effect of pharmacist intervention on medication adherence from other factors such as patient education on disease management and lifestyle modification. This complexity made it difficult to attribute outcomes solely to pharmacist interventions. Similarly, the review often could not isolate the effects of the pharmacist's interventions from other concurrent interventions or strategies such as reduced out-of-pocket costs for patients and team-based care. In some studies, the healthcare cost estimates were missing some key components. And lastly, many of the included studies had relatively short time horizons of 12 months or less. This limited time frame may not adequately capture the long-term effects of the interventions on healthcare cost and outcome. Next slide, please. Additional research and evaluation are needed to answer the following questions and fill the existing gap in the evidence from the review of the literature. And some of these questions are listed below, listed on the slide, as you can see. Are these interventions cost effective for patients with existing cardiovascular disease? What are the economic outcomes when interventions are implemented in rural area? What components of healthcare use lead to the greatest change in healthcare costs following implementation? Next slide, please. In conclusion, the findings of the Community Preventive Service Task Force are based on the application of decision tables and the observation that the median cost per quality adjusted live year gained at $11,298 falls well below the conservative threshold of $50,000. Notably, even the third quartile of the cost per quality adjusted live year estimate is well below this threshold. And based on these findings, the CPSTF recommended that the intervention was cost effective based on the median cost per quality adjusted live years gain of $11,298, which is well below the conservative threshold of $50,000. In conclusion, these summaries affirm the cost effectiveness of the pharmacy-based interventions for cardiovascular disease prevention, marking them as a valuable and efficient approach to improving healthcare outcomes. Next slide, please. In this section, I will be discussing resources for implementing CPSTF recommended pharmacy interventions to improve medication adherence. Next slide, please. The Joint Commission of Pharmacy Practitioners developed the patient care process to address medication non-adherence for chronic diseases. Steps in the process, which include collect, assess, plan, implement, follow up, and monitor, closely align with the process for selecting tailored action that address or reduce patient adherence barriers. Strategies that support the pharmacist patient care process and tailored pharmacy-based intervention may include medication therapy management, the appointment-based model, collaborative practice agreements, and text messaging. A key point to remember is that tailored pharmacy-based intervention may be implemented as one component of the broader pharmacist patient care process. This approach ensures a cohesive and structured way to address medication non-adherence. Next slide, please. I would like to highlight some select tools and resources from CDC's Division for Heart Disease and Stroke Prevention to help public health practitioners and state and local health departments find more information to implement tailored pharmacy-based intervention. To the left, we have the Advancing Team-Based Care through Collaborative Practice Agreements. This CDC resource and implementation guide defines collaborative practice agreements and provides information about state laws and other factors to consider. It also provides a template for drafting a sample collaborative practice agreement. And in the center, we will find using the pharmacist patient care process to manage high blood pressure. This CDC guide provides information about current resources and emerging practices, as well as tools and examples that pharmacists can use to help them improve health outcomes associated with cardiovascular disease. And pictured to the right is the interactive Atlas of Heart Disease and Stroke website. This is an interactive mapping resource that provides data and filter options, which include social and economic data, county-level blood pressure medication non-adherence, the number of pharmacies and drugstores, and the number of Medicare beneficiaries with heart disease. Next slide, please. And listed on this slide are the references from the presentation. Next slide, please. And included also are references of the 29 studies that were included for the economic review, that was for the systematic review. Next slide. Thank you.
Thank you, Dr. Owibu. Very important topic you present us. And we come back to the presentation of Professor Pedro Amariles again. Thank you, Professor.
Thank you. I try again.
Yes, we hear very nice now.
Okay. Again, good morning and good afternoon to pharmacists from different countries in the world. Thank you very much, Dr. Virginia Olmos. Thank you to FIP for inviting me to present some topics regarding adherence to cardiovascular medication. In these 15 minutes, I focus to present some keys regarding 4 topics. Number 1, general concepts regarding adherence. Number 2, prevalence and effects of medication adherence in patients living with cardiovascular disease. Number 3, challenge and barriers to medication adherence in patients living with cardiovascular disease. And number 4, perspectives to improve adherence to cardiovascular medication, mainly pharmacist intervention activities to improve adherence. Next, please. Regarding to general concepts, it is important to remember the concept of adherence. So, adherence is the extent to which a person's behavior corresponds with agreed recommendation from a healthcare provider. Next, medication adherence corresponding to the process by which patients take their medication as prescribed. In this process, it is possible to identify 3 phases. Number 1, initiation, also known as adoption or primary adherence. Number 2, implementation, also known as persistence or secondary adherence. And number 3, continuation. Next, the following graph shows these 3 phases and the associated 3 times of non-adherence. In primary non-adherence, patient does not initiate treatment. And in secondary or implementation non-adherence, patient delays, omits, or takes additional doses. And in continuation non-adherence, patient discontinued treatment. Next, please. Also, adherence could be detailed as an intentional non-adherence, which patient actively decide not to take a drug or follow treatment recommendation. It is like to reflect the patient attitudes to medication in general and their particular beliefs. Thus, it's very important of patient particular experiences and the views of others in informing the decision to take medication and concepts about the treatment recommended and the disease being treated. Right. Next, please. And an intentional non-adherence, that means that the adherence unplanned by the patient causes included misunderstanding and forgetfulness and factors beyond the patient's control, such as an inability to assess prescribed treatment. In addition, treatment complexity, cognitive impairment, costs, and other practical difficulties, for instance, open medicine bolus or difficulty swallowing pills, may reduce adherence. Next, please. Regarding to prevalence or no initiation of primary non-adherence in cardiovascular disease, overall, at least 10% of patients living with cardiovascular disease with cardiovascular risk factors never fill initial prescription, which is more notorious for statins and for antidiabetic drugs. Next, please. An actor is poor. For instance, in patients with hypertension, non-persistent percentages ranges between 30 and 80 in the first years after starting treatment. Next. Similarly, for secondary non-adherence and drug discontinuation, the figures show the magnitude of this problem. In developed countries, near to 50% of patients living with chronic disease does not adhere to drug or therapeutic recommendation. In patients with type 2 diabetes, adherence to oral antidiabetic drugs is 54. Between 40 and 75% of patients discontinue their starting therapy within 1 year after initiation. In cardiovascular disease prevention, some meta-analysis report the oral medication adherence is 57 at 2 years of follow-up. In primary prevention, adherence is 50%, and in secondary prevention, adherence is 66%. Next, please. Looking the adherence from a positive perspective, it is important to note the adherence to cardiovascular medication has many positive effects. For instance, avoid the use of treatment not necessary and potential anxiety, avoid to the development of cardiovascular disease and mortality in primary prevention, provide long-term cardiovascular disease benefits overall, improving medication adherence level, decrease the risk of cardiovascular events, stroke, and all causes of mortality. Therefore, better medication adherence is associated with a reduced risk of cardiovascular events, stroke, and all causes of mortality. Next, please. Overall, high adherence is associated with better clinical and economical endpoints. Next, please. In this way, Several systematic reviews evidence a dose-response relation inverse among cardiovascular medication adherence and health outcomes. Thus, the increase in adherence is associated to the reduction of cardiovascular disease. Next, please. A stroke. Next, please. And mortality risk. Next, please. Also, in patients with hypertension, high adherence is associated to a protective effects of cardiovascular disease events. Therefore, improving medication adherence may provide long-term cardiovascular disease benefits. Next, please. Regarding to challenges and barriers to adherence medication, adherence is a multidimensional event that is defined by 6 factors: socioeconomic and sociodemographic relates, healthcare system team relates, patient relates, treatment and therapy relates, disease and condition relates, and electronic health records relates. Thus, one of the challenges for healthcare professionals to improve adherence is to consider the perception and knowledge that patients have about their disease and how they understand the disease with regard both health education and medical treatment. Next, please. This is an important graph that shows the integral picture regarding factors that influence non-adherence. As he was denoted before, adherence is associated with patient relates, including physical factors and physiological behavior, disease and therapy relates, provider relates, health system relates, socioeconomic and demographic, including sex, age relates, electronic health records complexity relates. Next, please. Patients' beliefs about their condition and medication, for instance, side effects, play a stronger role in non-adherence, being more important than clinical or sociodemographic factors. Therefore, a misbalance between perceived risk, poor acceptance, understanding of cardiovascular risk, and those about the benefits of drugs, for instance, statins or asymptomatic condition, decrease non-adherence. In addition, drug costs or high co-payments, younger or older age, high number of comorbidities, polypharmacy, low income, and lack of social support contributed to non-adherence. Next, please. Particularly regarding to age, in patients between 30 and 50 years old or with 70 years or older, the non-adherence is more notorious, as she more in this graph. Next, please. Regarding perspectives to improve adherence to cardiovascular medication, let me to present some comments. Educational intervention improve adherence in patient knowledge. However, their impacts on adherence typically decrease over time. Shared decision making, including the use of decision aids, increase patient knowledge, but hit lack of consistency in adherence improve. Interventions by pharmacists tailored to patient needs and involving both face-to-face and telephone follow-up improved adherence. Motivational interviewing improves adherence. Next, please. Next. There is evidence of behavior. Previous, I'm sorry. There is evidence of behavior change intervention to improve adherence, mainly intentional non-adherence. Health promoting programs and prescription and personalized therapies improve therapy adherence. Intervention, including helping patients with drug side effects, seem to be particularly effective in improving adherence to oral antidiabetic treatment. Software solution. designate to patient-facing, including integrate components of disease care and deliver personalized patient management tools, also improve adherence. Next, please. Overall, given the complexity of causes underlying non-adherence, successful strategies will be tailored to each patient, including co-payment reduction, automatic reminders, mail-order pharmacies, counseling with health professionals, and fixed doses combination therapy. In this way, dose simplification, patient education, electronic reminders, and reduced patient costs or incentives are effective intervention to improve adherence. APP-based medication adherence intervention may have positive effects on patient adherence. Overall, multi-phase intervention, including health education, together with regular patient contact or follow-up, improve adherence. Next, please. Regarding to drug therapy, a high frequency of dosing is a risk factor for non-adherence. Thus, the best evidence suggests that taking medication once daily decreases the risk of non-adherence to treatment by 50%. Next, please. In this context, fixed doses combination therapy, known as a polypill, fixed doses with 3, 4, or more drugs in a single tablet or capsule, improve both the adherence and the clinical outcomes. For instance, polypill could be an effective and convenient therapy in both secondary and primary prevention of cardiovascular disease, which has been evidenced with the use of perindopril, indapamide, and lodipine in a single pill in real-life clinical practice and facilitates the achievement of BP control goals. Next, please. Also, it is important to denote that there is evidence that pharmacist intervention improve medication adherence and are cost-effective for cardiovascular disease prevention. In this way, the following table shows different strategies for improving antihypertensive medication adherence, categorized by stakeholders, including pharmacy. Next, please. This table shows different interventions from a pharmacy to improve adherence. There are very important reference to in consideration. Next, please. Finally, let me to present 5 key points. Number 1, medication adherence is the process by which patients take their medication as prescribed, and it is composed of 3 phases: initiation or first adherence, implementation or persistence or secondary adherence, and continuation. Also, adherence may be intentional or not intentional. Number 2, non-adherence is a notorious drug problem use. Unless 10% of patients living with cardiovascular disease or with cardiovascular risk factors never fill an initial prescription. In addition, in patients on primary or secondary prevention, the prevalence of adherence is 50% and 66% respectively. Number 3, there is evidence of positive effects of improved medication adherence in patients living with cardiovascular disease, including improved or long-term or cardiovascular disease benefits. There is an inverse relation with risk of cardiovascular disease, stroke, and mortality. Number 4, adherence is multifactorial. It is associated with disease, therapy, healthcare, patient, and social factors. Patient beliefs about their condition and medication, for instance, side effects, play a strong role in non-adherence. And finally, pharmacists may contribute to improve adherence through intervention. For instance, patient education, pharmacist consultation, motivational interviewing, refill reminders, text messaging reminders, electronic monitoring and feedback, and medication refile synchronization. Next, please. Thank you for attending me, and again, I excuse me by the limitation with initial presentation.
Thank you, Dr. Pedro Amariles. Well, we had three excellent and interesting presentations, and now we will move to our panel discussion. Some of the questions it was answering for the speakers in the Q&A chat, but we have some questions. The first is, as well see all drugs somehow affects our body and sometimes causes adverse effects. Is there any possibility that we work on boosting our natural immune systems and cure the cancer naturally without using synthetic drugs? Maybe some of our speakers can answer these questions. Maybe then Dr. Stefano Ombon. Okay.
Could you please, Pedro and Dr. Stefano, open your camera?
Yes.
Yes,
Yes.
I'm answering the question.
Do we have more questions, Virginia?
Yes. The next question is, CVD patients are always on multiple medications with high risk of interaction and serious side effects, such as GI symptoms, and clinical pharmacists are always challenged to optimize medication care and safety while persuading physicians to adjust or give up on certain medications that may be harmful. So the question is, shouldn't pharmaceutical companies work on providing CV medication as single combined dosage in order to solve this debate? Maybe Pedro, you can answer this question.
Yes, I don't know. As of the question is relation with polypill.
Yes.
There are many evidence that polypill is a very important strategy for improved adherence. There are systematic reviews and some meta-analysis that prove that this strategy improve adherence, and very important, improved adherence is associated to reduce the risk of cardiovascular disease, reduce the risk of stroke, and more important, reduce the mortality. I believe that polypill is a important strategy that will use to improve adherence. So pharmacy is intervention. There are many evidence that this kind of intervention leading by pharmacists improve adherence. I believe that there is an opportunity to pharmacists to working to patient to team healthcare team to improve adherence. Thank you.
Okay, thank you, Dr. Maris. And the other question is, comment on tips of adherence to patients with polypharmacy, maybe for Dr. Amariles too. Pedro?
please could you repeat
Yes.
the
Yes, comment on tips on adherence to patient with polypharmacy. Some tips for maintaining the adherence.
yeah, there are many interventions. I believe that patient education is very important. I had to try to identify the benefits and risks of treatment. All the cell monitoring is important. I believe that text messaging reminders and other strategies that have proved that improved adherence could be used in this situation.
Thank you. And we have the last question because we don't have enough time, but all the question, it will be response for the speakers by email, and the last is for Dr. Owibu. In your opinion, what is the simplest and most cost-effective intervention that a pharmacist can provide to patients with CVD in all regions of the world? Dr. Owibu, you can hear me?
Dr. we will have to leave, so I think we don't have him with us here. And if you have one more question, Virginia, to Pedro or Dr. Stefano, we can go, and then we need to leave one take-home message.
Yes, no, we don't have enough time. We have some questions, but it's better to answer by email. And we are almost at the end of our event. So I would like to ask each of our panelists to provide a practical take-home message for pharmacists listening, please. A short message. Dr. Stefano Boni.
I start first.
Yes, thank you.
As a doctor working with pharmacists, I think my suggestion is to try in the future to increase the collaboration between doctors and pharmacists, particularly for the management of cardiovascular disease and for prevention of cardiovascular disease, because this is very important. Because as doctors, we see usually patients only during the visit, and we need someone that can in some way support the patient, the treated patients between the visits. So I think collaboration is very important. And with the new technologies, digital health and telemedicine, this will be easy, much easier than in the past. And I think this collaboration should be strongly supported.
Thank you. Very important message. Pedro, do you want to?
Yes, thank you. I believe that non-adherence is a notorious problem. It is needed to use strategies to improve adherence. I believe that patient education is an important component to improve adherence. He needed to resolve those concepts about side effects, about it is important to the patient know the importance to that treatment for improve their condition. It is important to remember that medication do not work in patients who do not take them. I would say it's reflection very important about this subject. It is important that all health professionals working together to improve adherence, because it's very necessary to improve health outcomes. And improve the quality of life of patients. Thank you very much for this opportunity to present this consideration.
Oh, thank you for share with your knowledge with us in our webinar. Now we redo the poll to see if any of the answer changed, and please we invite you to choose one of the answer, the same question. One for solving intentional non-adherence. The intervention that could be more effective is the four possibility: motivational interviewing, educational interventions, shared decision making, including the use of decision aids, employing effective database. Well, the second, please. Which item in the list may not be considered a direct pharmacist intervention in a multidisciplinary team? Monitoring patient outcomes, medication dispensing, collaborative medication management, detection, prevention, or control of specific cardiovascular risk factors. Okay, the result is in this. And the last, the three, please. True or false? The Community Prevent Service Task Force find tailored pharmacy-based adherence intervention cost-effective for cardiovascular disease prevention. Please choose one of them. Well, it's true for the majority. Well, we finished our webinar. Thank you, the audience, for joining with us this webinar, and of course, thank you the excellent speakers for share your knowledge and your experience with us.
Thank you.
Thank you very much. And again, excuse by the limitation with my PC.